also about radiation safety in the OT. So I'll speak along these lines. First of a little introduction, then about basics about CM, about fluoroscopic images, basic steps for spinal injections. This will be continued by my next colleague, Dr. Ashik, about radiation safety, and then a slight take-home message for all. Introduction, always better to remember the scientist who's given us X-rays. So Konrad Röntgen discovered the X-ray in 1895 and was awarded the inaugural Nobel Prize in Physics in 1901. What is fluoroscopy? So fluoroscopy is a type of medical imaging that shows continuous X-ray images on a monitor. Why we need fluoroscopy? So because as sir said, it is real time. You don't have to send the patient to the X-ray department and get a X-ray done. There's no dark room required like for a normal X-ray. It is easy to use, fairly easy to use. You can magnify the image and you can increase the brightness, and it is safe to use. So what is CM? The image which we have seen just now. CM consists of an X-ray tube, a CM arch, an image intensifier, a control panel, and an image display system. So here the fluoroscopic beam comes from the tube, penetrates the body, sending the image to the intensifier. The image is then displayed on the screen for review. CM can be rotated in different directions to view the object from different angles. So this is the CM. This is your X-ray tube. This is the intensifier. This is the screen. This is the control panel, and this is the foot switch. You also have a handheld device sometimes. So these are the views. This is your regular AP view. So generally, traditionally, convention is patient is lying prone on a table, the CM is on the right, you're on the left. So this becomes your ipsilateral oblique, this becomes your contralateral oblique. Simple terms, this is your right oblique, left oblique. These are your lateral views. This is tilt. So this helps, I'll come back to this helps for squaring of the vertebra. I'll come back and explain how. So what I want to teach you is how fluoroscopic image is, how to understand it from the basics. So a photograph and a fluoroscopic image are both two-dimensional pictures. However, both have striking differences. So this is a photograph of a model of lumbar vertebra. This is the fluoroscopic image of the same. So here you can only see the body. You cannot see what is in front of it or behind it. Here you can see everything. So what I'll try to do is I'll try to deconstruct this. I'll try to explain how each and every image is formed. Because our goal is to inject appropriate medications in and around the target area of the spine, it is essential to understand the relationship between the fluoroscopic images, needle placement, and the target area. So for an example, if you take an X-ray image of a cylinder, what you see is a rectangular beam on the screen. You can take it from either side, from any angle, you'll see just a rectangle. So we cannot view the cylinder from ends. So by reviewing a series of images of this object, only then can you mentally construct a 3D picture of the cylinder, like from up and down and other sides. This is what I mean. So you take a cylinder, you take an X-ray shot, you will only see a rectangle here on the screen. So if a fluoroscopic beam similarly goes through a cube, it will display a square. Why I am telling you all this, I will come to it in the next few slides. The cylinder is placed on top of the cube. You will see a square with a circle in the middle. You are unable to, you can only judge the exact relationship without adding pictures from a different view. So this is what I mean. When you take a cube, you will see a square. When you put a cylinder on a cube, you will see a circle within the square. But to understand it completely, you need different views. So we'll consider each vertebra is built up by several blocks, like your Lego sets, for example. So lamina in the vertebral body, in a vertebral structure, is flat bone. Pedicle is cylindrical. This is where I am coming to. Let us illustrate how you build typical lumbar vertebra building blocks in order to understand that fluoroscopic image. So this is your typical lumbar vertebra. This is your body, and these are the other structures here. So if you break it down, this cylindrical area is your pedicle. This is your body. These are your superior articular pillar and inferior articular pillar. This is lamina, which is flat, the spinous process and the two transverse process. So when you take an X-ray shot, the X-ray beam passes through each and every part of the vertebra. So all of them then get juxtaposed and you get the final image. So the final image you get is this. So now you can appreciate why I was trying to tell you there is a circle within a square. So this circle is your pedicle. So 2D image of a vertebra is like a puzzle, and 2D image of each piece of the vertebra is a single puzzle piece. So this will help you appreciate better. So the X-ray beam passes through all parts of the body, and all of them are represented here in that image. So when you, each of them is a puzzle piece. So this is your lamina, this is your vertebral body, this is your pedicle, these are your superior and inferior articular pillars. So all of them, when they combine, this is what you get. I hope it is clear. This is your pedicle, this is your spinous process, this is your transverse process. Now let's come to basic steps of a fluoroscopic guided interventions. You deal with this in terms of these 5 steps. You identify your target point, whether you are going ahead with the transforaminal epidural, whether you are going ahead with your facet joint injections. So you first need to identify your target point. So identification is done in your AP view, 0 AP. Then you have to obtain all views under fluoroscopy and insert a needle. Both these are dynamic changes. You keep doing it with each other. For example, an oblique view will help you to enter. It guides your needle entry, and correct depth, verifying the correct needle placement is done with the lateral view and contrast agent. So lateral view will help with depth of the needle, and then you can inject the appropriate medicine which you've already decided on. So like I said, most of the interventions are done in prone position. This is what I was talking about. The C-arm will be on the opposite side. You stand here. So on the right of the patient is the C-arm, you are on the left. So conventionally, wherever the side of the lesion, when you take the X-ray that side, you can call it right, left, or ipsilateral and contralateral oblique. So these are the paths you see on an anterior posterior view of the lumbar spine. Now it becomes easy to understand. The midline here is the spinous process. The circle within the square is your pedicle because it is a cylindrical object. This is your transverse process, just outside the bony silhouette. Then these lines just above the pedicle are your superior articular pillar and inferior articular pillar, and the number 2 here is your lamina. Let's come to oblique view. So this is your classic Scotty dog appearance. You see it on an oblique view of the lumbar spine. So I'll go to the next slide once so you can appreciate it better. So this is like your true AP. This is a 10 degree lateral, 10 degree oblique, 20 degree and 30 degree, for example. So how to, suppose someone shows you this image and this image. How do you make out which is AP and which is oblique? So a simple trick is check for the spinous process. So in an oblique image, the spinal process will be far away from the margin of the opposite vertebral body. So the distance remains the same, but it appears it is going far away. As we move obliquely, you can appreciate the spinous process going far away from the vertebral body. Here it is in midline. Here it is far away from the edge of the vertebral body. So that is how you can appreciate it as an oblique view. And then how to identify structures on an oblique view. So here comes in the classic Scotty dog, where the eye of the dog is your pedicle, the circular structure. We'll show it to you better in the workshop during the procedure, but if you can appreciate it, I'll be happy. This is your eye of the pedicle, eye of the Scotty dog, which is the pedicle. The ear is the superior articular pillar. The nose is the transverse process. The forelimbs are your inferior articular pillar. This is the lateral view. This is how your lumbar vertebra looks in a lateral view. The one added thing here is this is your intervertebral foramen. So this is where all your spinal roots exit. So you can see when you the pic sir showed with the contrast. So that contrast was delineating the exiting nerve root, the L4-5 which sir had shown. So that is where we give that is the endpoint of our needle. In a lateral view, we confirm the endpoint for a transforaminal epidural. And the contrast which was delineating nerve root. The traversing nerve root goes like this. The spinal nerves which exit out of the intervertebral foramen are delineated here. They come out just out through this intervertebral foramen. So again, AP view is to identify the target point, like I said. Oblique view helps with your needle entry. Lateral view is to determine the depth of the needle. And contrast is to verify the accurate placement of the needle tip. So contrast will help you with exact delineating the exiting nerve root. Coming to radiation safety, so this is physics. When a human body is exposed to ionizing radiation, there is an interaction with the human atoms that results in energy transfer. This is called absorption. So the absorbed dose is the quantity used to evaluate the amount of radiation energy that is deposited into an absorbing medium, for example human tissue. So the absorbed dose is described in Gray units or the older rad units. So 1 Gray is 1 joule per kg. So this is a unit of energy, whereas REM, which is a rad equivalent in man, is a unit of exposure. So what our TLD batches count is that REM. So REM is used for monitoring radiation patterns. 1 REM is equivalent to 0.01 sieverts. That is another unit of exposure. So this is what the TLD batches measure. Annual limits of exposure to healthcare workers are 5,000 milligrams to the body, 15,000 to the legs, and 50,000 to the extremities. So while performing procedures under fluoroscopy, the goal is to minimize absorbed dose to the skin and to reduce radiation scatter from patient to physician and staff. So this is where our mannequins come in. Mannequins reduce the scatter from the, instead of patient, the mannequin will reduce the scatter. Typically, a skin absorbs radiation at the rate of 2 to 5 rads per minute. Radiation injury to skin occurs at the following thresholds. For 3 Grays of exposure, you can get temporary epilation of hair removal. Up to 6 Grays, you can see erythema, and then up to 20 Grays, you see desquamation, dermal necrosis, and ulceration. So, what are the steps we can use to minimize exposure? So, on the screen which we saw, you can use the last image on the screen to help with needle adjustment in the next image before the next shoot. You can use a pulsed mode to greatly reduce exposure because it reduces the number of frames per second, which reduces the emitted dose of radiation. You can keep the image within the patient's body limits so as to reduce scatter again. Use collimation. This is a technique to reduce the size of the X-ray field. It is of 2 types. It also reduces scatter. Limit personnel in the procedure room. People who are not required, you can keep them out. Whenever possible, intermittent fluoroscopy should be used to minimize radiation dose. Continuous, generally, as we all know, is used in cath labs. Pain medicine interventional practice, continuous is used in one place, especially when you want to make sure that it is not in the blood vessel. So you do a continuous shoot, if it disappears, then you know you are in a blood vessel. So that is one place where you have to do continuous fluoroscopy in interventional pain practice. Stay away from the tube as much as possible. You can be close to the intensifier if you have to be there, but also limit the use of magnification and high-level fluoroscopic imaging. Lastly, equipment should be well maintained and serviced regularly to ensure good working order. Shielding, of course, lead aprons helps to decrease the exposure to physicians' organs by more than 90%. Thyroid shields will protect your gland from radiation, which can cause cancers. And recently, eyewear has also come. Protective lead eyewear can reduce the incidence of radiation-induced cataracts. So my take-home message is please wear lead aprons and thyroid collars at all times. Confirm accurate needle placement with the help of all views. Imagine that 3D figure in your mind, that will help you better. And always remember it is a 2D image, so different views are required. You cannot just go in one plane and do it. You have to confirm it with a lateral view. Thank you. And there's a flood in Assam, so